My name is Carl Christensen. I'm the current director of the Tolan Park Medical Treatment Clinic for Addiction Medicine and the current medical director of the Michigan Health Professional Recovery Program. I'm also a clinical associate professor in OBGYN and psychiatry at Wayne State Medical School. My disclaimers are that I have no current relationship with any pharmaceutical company. I am a consultant for Blue Cross Blue Shield of Michigan, as well as a DEA and Department of Justice for safe prescription practices. Everybody's heard about all the dangers of opioid use, especially in adolescents and young patients, but the true story is that most people who start taking opioids do not get them from a doctor. They get them from a medicine cabinet. They get them from a friend, from a parent, and they start using opioids that way and then move on to getting their own prescriptions. But eventually the person responsible is going to be a physician or a provider who writes the prescriptions for these medications. This slide is a picture of a doctor working out of a clinic in Hamtramck. He came to the attention of the police when there were fights breaking out in front of his clinic because a line was running around the block and they couldn't fit enough people on the sidewalk. That's not a common problem in most doctors' offices. The neighboring clinics began complaining that there were too many patients trying to get pills. I believe that this physician turned out to be the number 6th or 7th largest prescriber of controlled substances in the U.S. So one question is, why do doctors do this? Why do they overprescribe? There's an old adage in addiction medicine that talks about the 4 Ds, which means why doctors write for too many pills for 4 different reasons. The first is that they're dishonest and they run pill mills and they're doing it for money, but this is actually a very small percentage of the doctors involved. The second category is a doctor who is not up to date or is dated on how dangerous these medications are and is surprised when he or she finds out that their patients have become addicted to Vicodin or other narcotics. The third group are the disabled doctors who are actually addicted themselves, which may or may not have anything to do with the pills they're writing, but anybody who is addicted has poor judgment and is very easy to convince that they should be writing for more pills. Also, they may be involved in criminal activity to split the pills with the patient. Then there's the fourth category, which is the duped doctor, who will tell you that I have to believe what the patient tells me, even if it may mean that they get medications that are unsafe. This is what happens if you write enough pills in a clinic. This is a patient who brought in a back x-ray to prove that he had chronic pain, and if you look at this x-ray, you'll see the patient has an extremely long coccyx or tailbone, which in this case is actually a tail. This is an x-ray of his dog, and he presented it as proof that he had back pain. And the doctor said, "How many Percocets do you want?" It turned out that this patient was an undercover DEA agent, and this doctor is no longer practicing medicine. Again, there's a very small minority of doctors that do this. Unfortunately, they get a lot of press, but again, it's the minority of overprescribing doctors. So what would you do, just briefly, if you suspect that a doctor is overprescribing? It comes down to whether or not you think it's a criminal activity or whether you think the doctor themselves is addicted or disabled. If you think it's a criminal activity, there is a complaint line for the state of Michigan, 517-373-9196. They will not take information over the phone, they will want something in writing, but they will launch an investigation. If you think it's an addicted or disabled doctor, we have a program known as the Healthcare Professional Recovery Program. I'm the current medical director, and we would do our own investigation of whether or not that doctor was safe to practice. That number is 800-453-3784. So the first issue is, how do you make a diagnosis of addiction? Then, if you realize that you are writing for too many pills for your patient, what do you do about it? This means you have to have an idea about how to make an addiction diagnosis. This is a brief overview of how we do it. The first thing I do when I meet a patient is to ask to see their previous medical records. I really don't need to see them all the time. I simply want to see what the patient will say. If they refuse to let me contact the previous physician, I know that it's not a simple pain problem and something more will need to be dealt with. Next is going to be the physical exam, and caregivers are familiar with the signs of addiction. You can have, for example, nicotine-stained fingers. You can have injection marks in the elbows and forearms. You'll see somebody in the middle of summer wearing a long sleeve shirt or sweater so you can't see their elbows. If somebody is snorting cocaine, you may see a very irritated nose, or you may actually see the cocaine residue, or the patient will be obviously intoxicated or in withdrawal. Anybody who is in opioid withdrawal will be sniffling, sneezing, they may be agitated, they'll have complaints of cramps, diarrhea, and they will be actively seeking opioids from you. Next is the urine drug screen. Drug screens have two functions. Number one is that you want to see the drugs you've been prescribed. If somebody is prescribed hydrocodone, for example, and it's not showing up on their drug screen, there are three possible explanations. One is that they're hoarding it, two is they're selling it, and three is they're taking it all at once or abusing it. All three of those are dangerous when it comes to narcotics. You also want to see if there are other drugs that should not be in the urine, and that would be drugs like cocaine, benzodiazepines, and marijuana. Also remember that some drugs will not show up unless you specifically ask for them, and those include methadone in some drug screens, fentanyl in most drug screens, and also buprenorphine or Suboxone. Your patient may be upset with you if you're testing them, and tell them, as I do, that I do universal screening for HIV and universal screening for addiction. It's not that I'm targeting that patient. The MAPS report, the Michigan Automated Prescription System Search, is extremely valuable. This is an example of a patient who I saw that came to see me for Suboxone. She said she had a problem with Vicodin. She was pregnant and she wasn't taking any other medications. We did a prescription search and it was positive for frequent prescriptions for Soma, which is a muscle relaxant, which we would never have found without a prescription search. And it turned out the patient was actually addicted to sedatives, and because of this was referred for residential treatment. Family interviews are important because if you're talking about addiction, addiction is a mental illness. You would not expect an addicted patient to be honest about their disease. The family may be able to confirm or deny that they have a problem. In addition, you want to make sure the family is stable. If it turns out there is a strong history of addiction in the family, you may be at risk by giving that patient a prescription, or they may be seeking disability, and you should also avoid prescribing medications in that situation. The last bullet here is multiple visits and evaluate for reliability. That's a polite way of saying that I'm wrong all the time. You need to see a patient more than once. Unfortunately, when someone is wrong, it is almost always because you believe the patient had a chronic pain problem, but they weren't telling the truth, and it turns out to be an addiction problem. It's very rare to diagnose somebody with addiction and later change it to a chronic pain diagnosis. So to make the diagnosis of addiction, you want to make sure it's not a pure pain diagnosis, and unfortunately, you can have both. If you have somebody who has chronic pain and addiction, you should definitely refer that patient to a specialist who works with both areas. You want to make sure the patient's not selling them, which would make somebody who had nothing in their urine, no matter what you tested it, the pills are all going right out the door, and this is not addiction. This is criminal activity. You can use either the Diagnostic Service Manual 4 criteria or the new DSM-5 criteria, or you can use what we call the 4 C's, which is craving, compulsion, loss of control, and use despite consequences. If your patient has more than one of these, and even if they exhibit craving alone, there is probably an element of addiction involved. When you see the patient for repeat visits, always make sure that you made the right diagnosis. So who do you typically see that wants an opioid prescription? There's the patient who has acute pain, who has a sprained knee or a broken finger, and we're not going to talk about them because those patients will need pain medications, and it really should be 1 or 2 prescriptions and not a repeated prescriptions. For somebody who has chronic pain, which is normally defined as pain lasting more than 4 to 6 months, and those patients may or may not need to be on opioids, and that's an entirely separate topic. It turns out that patients in chronic pain don't do very well when they keep on taking opioids for a long time. People who have chronic pain syndrome, meaning they have chronic pain and a psychiatric disorder, are the patients that you see that tend to be self-medicating and they are not truly addicted, but whenever they become anxious, they may take extra opioids or sedatives. If somebody who is malingering, and that means they're selling it and not using it, again, that doesn't really have anything to do with addiction. And finally, there is the patient for whom we use the fancy term has addiction with secondary gain. What that means is they are addicted and they are giving you a false history in order to get medications. We refer to that as a drugstore cowboy. This is a famous movie from the 1980s, and it shows what addicts will do to get a hold of your medications. There are classic warning signs for somebody who is a drugstore cowboy that I always go over with my medical students and residents. The first is that patients will come in on a Friday afternoon, and there are two good reasons for them doing this. One is that you know you have very little chance of finding the referring doctor. They also know that you want to get out of the office yourself, so they're hoping that you won't do a complete job and just give them a prescription. They can't tell you who the referring doctor was, or their doctor came from out of town. I had one run of patients who came from Nebraska. I assume there was a prison that closed, but they all told me that their doctors had unpronounceable names and couldn't remember who their doctor was. Also, the exam may not match the complaint. Now, you may have somebody with chronic pain who fits in that category, but this is just one warning sign. Also, they will ask for a specific narcotic. I've had people come in and say they were here for their Percs and Oxys, referring to Percocets and Oxycontin, which is a red flag, and I would not be able to comply with it. And finally, the most prognostic sign is when they leave your office, your prescription pad will leave with them, and then you have to contact the DEA and the local authorities, which is a lot of work. This is an example of a forged prescription. This is a case where I was contacted by the Akron, Ohio Narcotics Department wanting to know if I was prescribing Phenergan cough syrup with codeine for a patient named Rico Walker. This is a perfectly valid-looking prescription, but it's completely fictitious. We do not use this prescription. They wanted to know if I had written it for him. I told him this came from an OB clinic, Rico was not pregnant, and this was not my prescription, and I also added that since the signature was legible, it couldn't be my prescription either. Rico, I was told, wound up becoming arrested for this. So the next action is going to be, what do you do when you realize there's something wrong, that you're actually treating somebody who has addiction rather than simple pain? And the one immediate warning is that you need to stop prescribing. This is something the DEA is very firm about. Once you've made a diagnosis of addiction, you can't continue to prescribe that medication if it's a controlled substance other than Suboxone or buprenorphine, which we'll mention in a minute. This is a patient who was referred to me from northern Michigan who was pregnant. The assumption was that I was going to keep on writing her prescriptions. The chart said, quote, impression, opioid dependence, plan, methadone pills, 10 milligrams, 240, come back in 1 month. This is not legal. Methadone cannot be prescribed for addiction outside of a methadone clinic. And this is something we could not continue. So basically, once you've made a diagnosis of addiction, there are different treatment modalities, and we're only going to focus today on the medical. But there's also behavioral counseling, 12-step programs, and for eating disorders also there's bypass surgery. The two basic medical groups for addiction treatment are going to be agonists and antagonists. An agonist is very similar to the drug the patient is trying to stop using. There are only really two drugs approved in the U.S. One is buprenorphine or Suboxone, which is available in different brand names. Another brand name is Zubsolv, and it's available as generic buprenorphine. It's taken under the tongue for opiate dependency. You can also go to a methadone clinic for opiate addiction, but you cannot be prescribed methadone pills for opiate addiction. There's also nicotine for tobacco addiction, and some research programs will use THC for marijuana addiction, but that's not legal in the U.S. In Canada, also, you can get syringes of Dilaudid every day for heroin addiction, again, but not in the U.S. The other group is the antagonists, and that is the opposite effect that a drug has. There's only one that is currently active, and that is naltrexone. It's available in a pill form and injection form. The one that has really been found to be effective is the injection. It is not a narcotic, and since you get the injection in the office, you can't divert it. You can't sell it to somebody else after you give them the prescription. People are always confused when you hear about agonists and antagonists and partial agonists. So the way to think of this is comparing the potency of gasoline like high octane, low octane, or water. Methadone is the strongest agonist that can be used, so it's high octane fuel. Naltrexone is the opposite of the agonists, so this is like putting water in your gas tank. And finally, buprenorphine, which would be Suboxone or Zubsolv, is a partial agonist, which is low octane or low potency. The top two, methadone and buprenorphine, are both used to treat opioid dependence as agonists. The bottom line, without going over all the studies, is these drugs work about 40 to 60% of the time if you follow the patients for 1 to 2 years. That's the good news. The bad news is when these patients stop taking the medication and the medication is no longer around, it doesn't work, and they relapse. The relapse rates in different studies are 80 to 90% or higher. Once the patient relapses, there's also an increased chance of overdose, of death. It happens very often when people are released from jail or released from residential treatment and begin using. They're now very sensitive to the dose, and the dose that they used to use may kill them. Methadone, very quickly, is very effective. Your death rates go down, drug use goes down, crime goes down, HIV and hepatitis C also go down, and people have improved survival after getting out of prison. This is one slide showing an 80% decrease in IV drug use in New York City in 6 methadone clinics. It's very impressive. Unfortunately, these same patients will typically tell you they don't need to be on it anymore once they're sober, so they stop going to the methadone clinic. And here's what happens at the end of the 4 years in the methadone clinic, and here's what happens when they go back to using. 80% will relapse back onto IV drugs within 1 year of leaving the methadone clinic. So stopping these medications is not a solution because patients will typically relapse. Buprenorphine, also known as Suboxone or Zubsolv, is less potent. It is safer. There are far fewer deaths in the U.S. than there are with methadone. It can be given as a film or a tablet, and all of them go under the tongue. This is one slide showing that 2 years after starting, about 40% of patients in a Suboxone or buprenorphine clinic were still abstinent. This medication is effective. Unfortunately, when you stop it, the relapse rate needs to be called horrendous. It's about 95% in one large study. It can also be abused. It is dangerous when you mix it with benzodiazepines, muscle relaxers, or alcohol. And again, the relapse rate will exceed 90% when the patient stops receiving it. The last drug to talk about is injectable naltrexone. This is a study from Europe showing that more people on the medication will stay abstinent than control patients. The top line, the red line, is the drug group, and the bottom line is the placebo. This is a slide showing that patients who are on Vivitrol, which is injectable naltrexone, will also have a dramatic decrease in their craving scores. And remember, the craving is one of the 4 C's, or features of addiction, and it's probably the main reason for relapse. You can see that patients on Vivitrol, after about 2 or 3 months, will have a big decrease in their craving scores. And again, when patients stop taking the medication, they have an increased chance of death due to relapse because they are now sensitive to the heroin to which they were previously tolerant. It's also difficult to treat pain when a patient's on injectable naltrexone. They may need to go into the hospital to get pain relief for just a minor injury. The last issue here is that you do not have to use these medications. The most successful programs in the country are dealing with professionals who are medical professional and other programs. Ours is called the HPRP. For lawyers and judges, it's LJAP. And for pilots across the U.S., it's called the HIMSS program. These programs all have success rates of 80 to 90%. They don't use medications. They simply use very intensive monitoring, and if somebody has a relapse, they're put immediately back into treatment. And that's it. There's no medications used. So the issues are that addiction is a disease that is characterized primarily by craving and compulsive use, which means you have to use it. It can be treated with medications. It can be treated with behavioral programs. We've talked today about medications. It can also be treated with a comprehensive behavioral program such as the doctors, pilots, or lawyers. The issue is that addiction is not curable. We've shown you slides showing the relapse rates when the medications are stopped, but it's treatable. And it really is in the same category as high blood pressure, asthma, diabetes. Those diseases are also incurable. If you stop taking your insulin, you relapse. If you stop taking your blood pressure medication, your blood pressure will go back. But these medications or these treatments can all control chronic diseases that can't be cured.